So I've said a few times already that we need to titrate the fluids we're giving with the patient response. Well, what is this patient response that we need to look for? Well, the aim of giving fluid resuscitation or blood is that all the organs and tissues of the body are adequately perfused with adequate amounts of blood, and that blood is containing enough oxygen. That is the aim. So the aim is to make sure that all body tissues are well perfused and oxygenated. So how are we going to assess that? Well, one obvious one is that we can assess how well perfused the kidneys are, and we can do this by assessing hourly urine volumes. Now, to do this, unfortunately, we do need to catheterise these patients because the bladder can hold several hundred mils of urine, obviously, and we don't know when it was passed unless the patient is on continuous drainage and we're measuring that on an hourly basis. And for an adult, we want 0.5 mils of urine per kilogram of body weight per hour as a minimum. And if an adult is producing less than 0.5 mils of urine per kilogram per hour, then that patient is going into acute renal failure. But of course, if the urine volumes go up, then that's a very encouraging sign, meaning that the kidneys are well perfused. Now, in children, we want them to produce more. We want children to produce at least 1 mil of urine per hour per kilogram. And if you're looking after very young children, we want them to produce even more, maybe 2 mils of urine per hour per kilogram of body weight. And then the level of consciousness. And it's not just the level of consciousness, it's the whole perfusion of the brain. So if the brain is hypoperfused, the patient might feel anxious or agitated or even aggressive. You can get aggressive responses sometimes because the brain is not being perfused with oxygen. And when the patient sits up, do they feel dizzy when they sit up? So if a patient is not too bad when they're lying down, but then feels dizzy when they're sitting up, when the blood's got to go uphill to the brain, again, that's a sign that the brain is not being as well perfused as we would like it to be. Then there's peripheral perfusion. Has the patient got warm feet? Have they got warm hands? And we can assess that more formally with capillary refill, where we're going to press for 5 seconds and then make sure that the capillaries in the fingernail beds refill within 2 seconds, which is normal. Less than 2 seconds is going to be normal. Then we can monitor the ECG, the electrocardiogram, making sure that there's no irregular heartbeats or no more than we would expect normally. That the myocardium is not becoming irritable because it's hypoperfused or hypoxic. And then another useful indicator is the respiratory rate. Patients who are hypovolemic as a result of hemorrhage are going to be tachypneic. They're going to be breathing more quickly. And there's probably 2 reasons for this. One is if there's not enough blood going around the body, that's going to be detected in the carotid bodies, and that's going to stimulate respiratory effort as a result of oxygen lack. But the main mechanism probably is that if an organ or a muscle or anything is hypoperfused and it's not getting enough oxygen, it's going to be hypoxic, then it's going to change from the normal aerobic metabolism to anaerobic metabolism. And as you probably know, anaerobic metabolism results in the production of lactic acid, and the patient's going to get a degree of lactic acidosis. And the acidity of the blood is massively stimulating to the respiratory centre in the medulla oblongata, stimulating tachypnea. So if the patient was still breathing very rapidly, that's a bad sign. But if, as a result of your interventions, the respiratory rate was coming back down to a more near normal level, then again, that is another good clinical indicator. So check end organ perfusion and oxygenation using criteria such as urine output, level of consciousness and patient's mental state, peripheral perfusion, ECG, and the respiratory rate. Now, when we give fluid resuscitation intravenously, there's 3 types of responders: rapid responders, transient responders, or minimal or no responders. Let's think about those. The rapid responder, first of all. Now, the rapid responder has most likely not lost that much blood. And when we give them 1 bolus of intravenous fluid, they respond rapidly and they become normal again. Their observations become normal. They become hemodynamically normal. That means their parameters basically go back to normal levels. They've responded very well, and it's very satisfying for us. So a patient might come in, they've got the signs and symptoms of hemorrhagic hypovolemia, 1 dose of fluid, and they respond and become normal again. That's good. But it doesn't mean they don't need a surgical opinion. They still do. These patients may still need surgery. So just because we've been very clever in the A&E room doesn't mean we don't need a surgical opinion. We still do. Then there's the transient responder. So we run some fluid in, the blood pressure goes up for a period of time, but then it starts going down again. There's only a temporary response. And these patients have probably lost greater volumes of blood anyway, probably more than 20% of their volume. And it could mean that there's ongoing loss from somewhere, that they're still bleeding. So we've put some fluid in, but they're still bleeding out somewhere, so there's not enough net fluid left in the blood. Or it could mean we've been too timid with our fluid resuscitation and they need more fluids. Always bear that in mind, that they may need more fluids. And of course, these patients always need constantly reassessed as well. That's true in all emergency situations, constantly reassess the patient. Then we've got people where there is a minimal response or no response. And there's 2 possibilities here. Either this patient is suffering from exsanguinating hemorrhage. They're bleeding from a huge blood vessel somewhere, maybe into the thorax, abdomen, pelvis, multiple long bone fractures. And even though we're putting lots of fluid in, it's not enough to compensate for the blood which is still being lost. So even though they're lying in our A&E department, they're still bleeding. There's exsanguinating hemorrhage. This patient is in extreme danger if they're not responding. And always remember that hemorrhage is the most common cause of death in trauma. It's the most common cause of shock. But some people who are non-responders might have a Nun Hemorrhagic cause of their shock. So the vast majority of patients, their shock is going to be hemorrhagic after trauma. And if they don't respond, that means there's a big bleed somewhere. And unless we get some surgeon to clamp it off quickly, these patients are probably going to die. But there's another smaller group of patients who are non-responders because they don't have a hemorrhage problem. It's a Nun Hemorrhagic shock. And in the A&E situation, we might see this in terms of blunt myocardial injury, where there's been a blunt trauma to the chest, and that can stop the myocardium working properly. Or it could be a cardiac tamponade situation, where there's bleeding inside the peritoneal sac, compressing the heart, preventing venous filling of the heart, preventing cardiac filling so it can't contract properly. The heart just becomes compressed because of the cardiac tamponade. Or the other cause of non-responders in non-hemorrhagic patients is tension pneumothorax, where there's a tension pneumothorax pushing the mediastinum across, kinking the large vessels. So rapid responders, transient responders, minimal or no responders. Minimal or no responders are either suffering from exsanguinating hemorrhage or some non-hemorrhagic cause of the shock, meaning that they don't respond to fluid resuscitation. Types of responders: rapid, transient, minimal or none.